Hello, good afternoon. I hope you can hear me. Um, just taking a look if I can see you. I cannot see you at the moment, so I'm just waiting for the queue to see if I can get started with the program. Okay. Yes. Thanks. I'm getting the message that we can get started. So just shortly, my name is Jeroen Schouten. I work at the Radboud University Medical Center in the Netherlands. And I'm co-organizing the program Drive AMS Indonesia. And Drive AMS Indonesia is all about strengthening human capacity to tackle AMR through what we call contextualized education and implementation science. And AMR is for those who are not very aware of it, it stands for antimicrobial resistance, and it's truly a huge health threat all across the planet. It's called the silent pandemic as well, and it's important to recognize that this is also a threat in Southeast Asia. So it's definitely also a threat in Indonesia. And one of the major effective actions that are required to improve to reduce antimicrobial resistance is it's surveillance first of all, but it's also prudent antibiotic use. So knowing how to prescribe antibiotics appropriately, and we also call that stewardship. So that's where AMS stands for, antimicrobial stewardship. Now, the Drive AMS Indonesia program applies especially implementation science and behavior change approaches to improve that prescribing. And so we've set up a program over the last couple of years together with our partners in Indonesia who are all there. That is NAFIC, but it's also Kemenkes, very importantly, WHO Indonesia, and the Dutch counterparts, RVM and the Dutch Ministry of Health. And of course, working together with Prof. Anis, who's the director of the AMR program, to really create skill building approaches, helping hospitals to promote effective stewardship programs in their hospitals. So this session is going to be about that. And we're going to have an introduction first by Teske Schoffelen, who's a co-worker of mine here in Nijmegen in the Netherlands. She's also online. And then afterwards, we will hear Alalicia Limato, who is a PhD from Indonesia, who's been working from us since the start of this program, and who will tell a little bit about how the program was implemented in the Indonesian setting and how it aligns with the Indonesian AMR and AMS agenda. Then after those two presentations, Teske giving the background and Alicia giving more the contextual application of the program in Indonesia, we will turn back and have a panel discussion. And while you are listening to the introductory presentations, after that I will introduce the different the moderators and the speakers for that session, and we'll get started for another 40 minutes. So I hope you enjoy this, and let me just hand over now to Teske to start the presentation. Thank you.
Hello, everyone. Thank you for the introduction, Jeroen. I can see my own presentation on the screen, so I think I can start. So in the next 10 minutes or so, I'd like to take you through two things. First, a short background on antimicrobial resistance and antimicrobial stewardship. And second, the key features of the Drive AMS program. Next slide, please. Well, antimicrobial resistance, or AMR, is sometimes called the silent pandemic. Jeroen also mentioned it just now. But why silent? Well, that is because it grows slowly year after year, not with a shock or sudden outbreak like COVID, but quietly hidden in everyday infections. And yet the death toll keeps rising. Over the next 25 years, antimicrobial resistance will cause more deaths than HIV, malaria, and tuberculosis combined. And some projections even say it might surpass cancer as a global health threat. Next slide, please. So what does AMR, antimicrobial resistance actually mean? Well, most of you might know it, but some not. So to explain, it means that bacteria or fungi change in such a way that the medicines that once killed them, so antibiotics or antifungals, no longer work. So even a simple bladder infection or a wound infection can become dangerous because they are no longer treatable with the antibiotics, and that can lead to bloodstream infections and death. But also for complex treatments like organ transplantation or cancer treatments, the risk is that we simply cannot perform them anymore because the antibiotics we rely on may fail. Next slide. Why does it happen? Well, mainly because of overuse and misuse of antibiotics in people, in animals, and even in the environment. And when bacteria are exposed to antibiotics, the resistant ones survive and multiply. And over time, these resistant strains can spread, sometimes across hospitals, sometimes across the globe. Next slide, please. So what can we do? Next slide, please. Well, this is where antimicrobial stewardship, or AMS, comes in. And antimicrobial stewardship is about using antibiotics wisely and responsibly, making sure they remain effective in the future. And in the human healthcare domain, it is a persistent effort to measure and improve how antibiotics are prescribed by health professionals and used by patients. And the goals of antimicrobial stewardship are simple but important. So, first of all, prevent resistance, but also improve patient outcomes, reduce side effects, and deliver care that is cost effective. Around the world, hospitals are setting up AMS programs. So they bring together an AMS team to measure and improve how antibiotics are prescribed in the hospitals. But there is the challenge because antibiotics are prescribed by many different health professionals in the hospitals, and most are not specialists in the field. So that means a lot of incorrect prescribing. Next slide, please. To change this, these antimicrobial stewardship teams in hospitals don't just need their own expertise in infectious disease, microbiology, and antimicrobials. They also need skills from implementation science, the science of how to change behavior in practice. And because it is the antibiotic prescribing practice of the peers in their hospital that they need to improve, these antimicrobial stewardship teams need the knowledge and the skills on implementation science. And that's what they often miss. Next slide, please. Next slide, please. So this is where Drive AMS comes in. Drive AMS was developed at Radboud University Medical Center here in Nijmegen, the Netherlands. And it is actually the first postgraduate program worldwide that combines AMS with practical implementation skills, supporting hospitals with training and follow-up for up to 18 months in collaboration with local champions. Next slide, please. What makes Drive AMS unique? One slide back, please. Well, I already mentioned, so it focuses on how to implement stewardship activities, providing AMS teams with valuable insights and skills. It follows a training of trainers principle, building local capacity and adjustments to local contexts. It trains hospital teams, not just individuals, So these teams include clinicians, pharmacists, microbiologists, all working together in AMS teams in hospitals. And it is a hands-on and practical training. Teams work on their own antibiotic use problem from their own hospital. And we offer a structured and interactive approach. So in a 3 to 4 days masterclass, the teams follow a step-by-step approach. And we offer a long-term support, so up to 18 months while teams carry out their project in the hospital. Next slide, please. In this slide you see, next slide, please. Yes. This is a schematic overview of the Drive AMS program, and the program runs in 3 phases. So next slide, the first phase, the preparation phase, hospital teams are taught and equipped to measure antibiotic use in their hospital with a point prevalence survey, a PPS. And global PPS, developed by our partners at the University of Antwerp in Belgium, is offered as a methodology as it ensures a standardized and reliable method. Next slide, please. In the next phase, the teams prepare a project plan during a 3 to 4 days face-to-face Drive AMS masterclass. And hospital teams are then trained to design and implement projects tailored to their local context. And they learn about changing prescribing practices by just doing it. Next slide, please. And in this 3 to 4 days masterclass, hospital teams move step by step. So defining their problem on day 1, setting up measurements on day 2, analyzing barriers and finding solutions for that on day 3, and then presenting a project plan on day 4. Next slide, please. So all teams are guided through these 5 steps derived from implementation science while focusing on their own antibiotic prescribing problem. Next slide. So the last phase of the Drive AMS program, so after the training, is formed by that each hospital team starts their implementation project in their own hospital, for which they receive expert support from Drive AMS. And later they measure again to see the effect. Next slide, please. The first international Drive AMS masterclass was in 2019 in our hometown Nijmegen, the Netherlands, which was a very positive experience with postgraduate health professionals joining from around the globe. Next slide, please. So since then, the Drive AMS has spread rapidly to other countries, funded through different sources. More than 400 hospitals across 40 countries have participated, including Indonesia. The program works with local and national AMS champions, often through the train-the-trainer model that I already mentioned. Next slide, please. More information we provide on our website. There is the QR link. And then in the next slide, the effectiveness of Drive AMS has been studied in the first ESCMID AMS certificate cohort that is part of the European Society of Clinical Microbiology and Infectious Diseases. And following the Kirkpatrick model for evaluating effectiveness of trainings, we found that the courses were positively evaluated and that almost all participants passed the exam. So these are level 1 and level 2 respectively. And interestingly, 88% of participants completed an AMS project in their hospital within 2 years. And more than 80% showed positive results while remeasuring after the implementation, whether in prescribing practices, antibiotic use, or even patient outcomes. So these are level 3 and level 4 of the Kirkpatrick model. Next slide. So the project reports of this cohort are published online on the ESCMID website. And then I go to my last slide to summarize. Well, AMR is one of the greatest health threats of our time. Jeroen already mentioned that. Antimicrobial stewardship is essential, but it only works in hospitals if hospital AMS teams know not just what to do, but also how to do it. And that's what Drive AMS provides. It's a practical, structured, and team-based approach to making real changes in hospitals. More details on the Drive AMS approach are available in this practical guide, accessible through this QR link. And with that, I would like to end for now and give the floor back to the moderator. Thank you.
Thank you very much, Teske. That was, I think, very clear as an introduction. We won't have time for questions right now, but I'm sure that during the panel discussion that we will have later on, we can, of course, go into depth into what the program exactly looks like and how it is carried out. So it is now time for Rela Licia Limato, to start with giving a presentation on the Drive AMS program as it has been introduced in Indonesia. So the stage is yours, Licia.
Thank you, Jeroen. Hello, everyone. My name is Licia. So here I will present the implementation of Drive AMS program in Indonesia. Next, please. Next, please. Yeah. So the Drive AMS Indonesia is the collaboration between government and non-government partners, which includes in Indonesia the Ministry of Health and the WHO Indonesia, where we also partner with the Netherlands, with the Ministry of Health, Welfare and Sports, Radboud University Medical Center, and Nuffic Southeast Asia. We, as Teske said, we also collaborate with Global PPS. So the goal of Drive AMS in Indonesia is to strengthen the capacity of hospital in Indonesia by bringing Drive AMS approaches and experts from Indonesia and the Netherlands. So Drive AMS Indonesia aligns with the global effort to curb AMR. So there are many efforts. For example, the Global Action Plan on AMR and the UN political meeting where global leaders they committed to reduce AMR related death by 10% by 2030. In Indonesia, there are various policies that relates to curb AMR in Indonesia. We also have national action plan on AMR, national strategy on AMR control in health sectors, and specifically for hospitals, there are various policy which includes AMR program, AMR control program in hospitals, and also antimicrobial stewardship guidelines and policies. Next. So in Indonesia, there are 8 hospitals that participate in Drive AMS programs. This includes 3 hospitals that owned by Ministry of Health, 3 hospitals that owned by provincial or district, and then 2 private hospitals. So the purpose of variation of these hospitals that we would like to demonstrate that Drive AMS approach can work in diverse hospital settings, not only public or private hospitals. Yeah. Next. And in terms of the program timeline, so Drive AMS runs for 18 months. So we start the preparation in July 2024, where hospitals receive training on how to conduct antibiotic use, how to collect antibiotic use data using global PPS. And so between, after training, so it's July and so August and October, the hospitals, they were asked to collect the antibiotic use data. And then in October, we conducted 3 days training for the hospitals. Next slide. So in this training, the hospital was come with 5 people, which include the core AMS team and also hospital management. So together in this training, the Indonesian and Dutch faculty work together with the hospital to explore their problem that they found in the data collection, and also to develop strategies and plan how to improve their antimicrobial stewardship program in their hospital. Next. And so the next, after October, so between November 2024 and April 2026, so we expect the hospital, they will implement their intervention. So between this period, Drive AMS Indonesia, our team, we follow up the hospital to support them in their implementation until April 2026. But it doesn't mean that the hospital should stop their implementation after April. But this timeline, we expect that the implementation already embedded in the hospital, they have their ownership and they can continue their intervention. Next. Okay. So as part of the intervention, so the hospital, they made action plan and execute intervention. So some of the interventions selected by the hospital is first the antibiotic use policy, the hospital. And second, hospital also produce antibiotic use guideline. So the other intervention is to pre-authorize antibiotic prescribing in the hospital. And another one is to remind doctors that they have to stop the antibiotic after a certain period of time. And these reminders came from nurses and clinical pharmacists. Yeah. So there are various activities that conducted by the hospital before conduct the intervention. So it's of course like to have meetings with the hospital leadership, with doctors from all departments. They also conduct dissemination of the intervention, and to so doctors and nurses and all healthcare providers in the hospital, they understand about the intervention. Next, please. So Drive AMS team, we provide ongoing support to the hospital through regular meeting, monitoring process, technical assistance when needed, and also feedback. We in Indonesia, we have a regular meeting with the Dutch partner, with Jeroen and Teske, to discuss about the implementation progress as well as to find solution when there are problems during the implementation. And we also discuss the progress with the Ministry of Health, with the Indonesian faculty, and we also have a joint visit with the Ministry of Health when high-level engagement is needed. And so this process is very helpful because the support and feedback from the Ministry of Health, it's helped the FMS to have a backup from the authority, so the hospital can quickly, the problem can quickly reach the hospital leadership. So, sorry, before this, please go back. Sorry, please go back. It's again, maybe 3 slides. 3 slides back, please. Yeah, after this. Yeah, next. Next, please. Next. So these are the example that we conduct field visit with the hospital team to see the implementation in the on the ground. So what are their progress and what are the problems faced by the hospital stewardship team. Next, please. So hospital measures their progress by tracking certain outputs and outcomes. So for example, the prevalence of antibiotic use, the quantity of antibiotic use, the quality of antibiotic use, and also prescription compliance based on antibiotic guidance, as well as clinical outcomes and financial outcomes. And so these are the example of progress of one hospital where you can see like a downward trend of antibiotic use of two antibiotics after they perform intervention. And the same hospital, they started to calculate the savings when certain antibiotics is not prescribed. Next, please. Okay. So Drive AMS will lead research focusing on the process implementation, facilitators and barriers in the execution, sustainability plan, and the impact of JFMS program in Indonesia through interviews, focus group discussion, observation, and document review. Next. So in summary, JFMS Indonesia represents a collaborative program between Indonesia and the Netherlands by strengthening the antimicrobial stewardship capacity across diverse hospitals in Indonesia. So we hope the lesson learned will contribute to sustainability AMR effort in Indonesia, as well as can serve as a model of global collaboration. Thank you.
Thank you very much, Radalisha, and thank you to yourself as well, because of your endless efforts to keep the project going all together with the team at Nuffic, but also with us, of course. So we are going to prepare now for the discussion. So we have some time for discussion. And before we go over, I would like to introduce the panel members that are here for the discussion. Now, it's for me a little bit difficult to see from this far, but I am aware that we have a couple of panel members, and I'll just shortly introduce them to you. First of all, I'm going to start with introducing Buemi. I'm not sure I think she's joining online, and I can't see if she's already online at the moment. Maybe Adiba, you can tell us, but Buemi is from the Ministry of Health, Kemenkes, and she has been very instructive on the program and was present at the course in Bogor. Then, of course, we have Dr. Robert Cinto. I think he's present. I can see him through here, yes. So Robert Cinto is an ID physician at Cipto Hospital, and he has been a part of the faculty of Drive AMS Indonesia. Dr. Dewi is also there. She's a microbiologist and was a participant at the Drive AMS Indonesia course, so she may tell us a little bit about the experience that she had during this course. We have Peter van Tel, who's a representative of the educational partner, that is Nuffic Southeast Asia. And then online, I can already see that Caroline Russen has joined, and Caroline is the International Coordinator for Surveillance of Antimicrobial Resistance at the RIVM, right? The RIVM is the National Institute for Public Health and the Environment in the Netherlands. And this whole program came to a start through the collaboration between RIVM, the Dutch Ministry of Health, and of course, Kemenkes when we started collaborating. Now, I didn't mention one important person because she's the co-moderator, and that is Prof. Dr. Anis Karinawati. She's the chairperson of the Antimicrobial Resistance Control Committee in Indonesia, and is a very seasoned researcher and a policy expert in stewardship. and in AMR in general. She's a microbiologist in background, and I would like to maybe hand over words to Prof. Dr. Anis to maybe start the conversation from there. So thank you very much,
Yeah.
Prof. Anis.
Thank you, Jeroen. So I think I don't know how to. We want to see you, but if you want to see me, then I have to turn my.
I can see you. Don't worry. Just
Yeah.
that I will look at the side of you.
Yeah. Okay. So good afternoon, everyone. So we have 1, 2, 3, 4, 5 panelists here, and also with Dr. Alicia, we have already heard about the uh, a comprehensive introduction about Drive AMS and also the implementation of Drive AMS in Indonesia. So I think we need to know more about this problem, the AMR problem, because we face also very big problem here in Indonesia. So now we have Dr. Ami from the Ministry of Health. So she is the team leader in AMR control in the Ministry of Health Indonesia. So, Ibu Ami, what are actually the current key priorities to tackling AMR in Indonesia? And so please also tell us about the main opportunities and challenges that we face in implementing the AMS in Indonesia. Please, Bu Ami. Hello, Bu Ami. Do you hear me? She cannot hear me?
Okay,
Yes.
I believe she cannot hear you, or she's not
I think,
currently in the room. Maybe we can start with another question and then maybe ask,
yeah.
see if she will join a little bit later.
Yeah. So, Bu Ami, hello. So she already unmute actually.
Ah,
Yeah. So please, the committee, you check the accessibility of Bu Ami. Yeah. So the next question is for Dr. Caroline Rusen. Hello, Caroline. Do you hear me?
Yes, I can hear
Yes.
you.
Very good.
Hello.
Yeah, so the question is from the Dutch perspective, what are the main opportunities and challenges and advancing initiatives to curb AMR, including AMS implementation?
Yeah, first of all, thank you, Professor Anis, and thanks for the organizing committee for inviting me to this important session. So I speak from the Dutch perspective. Personally, I work on AMR surveillance, and I think AMR surveillance and antimicrobial stewardship are very intertwined. I think the one cannot go without the other. So in the Netherlands, maybe as a bit of background, I think antimicrobial stewardship and A teams, so antimicrobial stewardship teams, have been implemented in Dutch hospitals since 2014, so already quite a long time. So I think in general, so from a Dutch perspective, but also in general, I think there are three pillars that are crucial for combating AMR. And the first pillar is antimicrobial resistance surveillance. So to actually generate the data to better understand what is going on. So both in the local context, but also nationally and internationally. And this data will help to generate information for action. And this information can be used, for instance, to build empirical therapy guidelines. And these data can also be used to assess whether AMR interventions are actually effective and to assess the impact of these interventions. So I think that's the first pillar. And then the second pillar is definitely antimicrobial stewardship. And as I said, these are very intertwined. So to be able to do good antimicrobial stewardship, you need to have good data to base your empirical therapy guidelines on, and to really understand the epidemiology. And then the third pillar is, I think, infection prevention and control, because I think there's no better way to control AMR than by preventing infections in the first place. And maybe there's a fourth pillar, or actually this is more a prerequisite for all these three pillars, and that is to have good quality clinical microbiology diagnostics, as all these three pillars start with having good quality diagnostics in place. So the clinical microbiology labs are of utmost importance, I would say. Thanks. Over to you.
Yeah, thank you, Caroline. Yeah, so, Bu Ami, do you hear me? Not yet. Okay, then, so we proceed to Dr. Robert. So, Dr. Robert, you are a clinician in our biggest hospital in Indonesia. So, from your clinical work as an infectious disease specialist, and also your experience in studying the implementation of AMS, in Indonesia. So, how do you describe the situation in Indonesia?
Thank you, Prof. Anis, and thank you for the organizing committee for having me in this panel discussion. So, on 2023, we conducted a nationwide implementation study to see how far the implementation of antimicrobial stewardship in Indonesia. We invited 3,000 hospitals across all sides of Indonesia, and 600 hospitals respond to our survey. And we conclude that from the 600 hospital, 80% is in the intermediate level of the EMS implementation. Only 10% in the advanced. Advanced, it means that they all have the all infrastructure and all the procedure and all the monitoring process of the EMS. But 10% only in the basic level of the EMS implementation. So they only have the document, but no activity of ESP, antimicrobial stewardship, happen in the hospital. So there's perhaps the big description of how the level of the EMS implementation in Indonesia.
Thank you. And what are the most pressing needs to improve and sustain the AMS implementation, including outcome evaluation in Indonesia?
Thank you, Profani. So we point out there's three basic limitations that we found in the survey. The first one is the availability of the infrastructure. So for example, the microbiology lab is lacked in most of hospitals in Indonesia. Only about 40% of the hospitals have the microbiology lab or access to microbiology lab. That's the sample of the infrastructure. We don't talk about the IT because Caroline already talked about the data, and the data is much more easily gathered if we get the IT access to access all of the data, the hospital data. That's the infrastructure things, number one. Second one is the ESP implementation. So not only 50% hospital that go with the prospective audit, they go with the pre-authorization system. So the implementation is not there for most of 40 until 50% of hospital. And the third one is about the monitoring, audit, and feedback. And as we linked with the lack of IT, so they have no monitoring, no audit, no reporting. And we know that as the scheme of the improvement, the monitoring, audit, feedback is something that's very important. So those three things is the major pressing things of the lack of implementation of ESP in Indonesian context.
Thank you, Dr. Robert. So next, Dr. Dewi. Dr. Dewi works in the private hospital in Sumatra, and is, her hospital is one of the participants in Drive AMS implementation. So please tell us about your experience in implementing the Drive AMS, and also with the regard of the AMS implementation, in what ways does the Drive AMS approach different from other approach that you have known and already we have done it since 2015 with this the Kaizen criteria. Please.
Okay, thank you, Prof. Anis. First, I want to say thank you to Ministry of Health Republic of Indonesia and also Drive AMS team to give us the opportunity at Hospital Pekanbaru as a part of Drive AMS program. Um, Drive AMS program is different from the other EMS approach in several ways. Uh, First, Drive AMS teach us how to develop the AMS project step by step. We learn how to identify our biggest problem in our hospital, how to make the explore the determinant, create the indicator, and plan the evaluation and choose the intervention. So it made the project become comprehensive and also focused. The second one, Drive IMS approach is bottom up and also based on the real hospital need. So the project that we build is based on the biggest problem in our hospital. That is the second one. And it is different with the other uh, approach in Indonesia. Like the approach is often top and down and based on the general guideline of AMS. The third one, at the end of the training, we already had a draft of project that implement to our hospital when we come back to the hospital. And after that, Drive IMS also have conducted two follow-up visits to our hospital, and it make some pressure in positive way for us to still commit with the project. So I think it's a real change process, not only the training. And finally, of course, in Drive IMS program, we receive uh, the comprehensive lesson from the prof Jerung, Dr. Teske, and also Prof. Anis, Dr. Robert Tinto, and Dr. Licia. And also valuable input based on tailor based on our project. And especially Dr. Alicia still available to listen the problem or challenges from our hospital. So we felt encouraged and not alone in our EMS journey.
Yeah. And currently, do you still do it?
Yeah, of
Yeah.
course. So maybe I can explain about our project in Eka Hospital Pekanbaru. The project in Eka Hospital Pekanbaru is called BOOST project. A big outcome by a single dose antibiotic prophylaxis treatment. We choose this problem based on the global TPS audit antibiotic that teach by Drive AMS. Uh, um, so we start the project by discussing it with hospital leadership, with the medical committee and also quality committee and head of surgery department. And after this, we introduce the program to the surgeon. Based on the discussion, we decide to use both soft approach like education, made the leaflet that educate about antibiotic prophylaxis, but we also use the firm approach. We apply a pre-authorization system for antibiotic prophylaxis. Before we do the pre-authorization only for watch or reserve antibiotic. But in this project, we also apply it in antibiotic prophylaxis. And also we revise our guideline prophylaxis and also the treatment antibiotic guideline. And in revision, we make a discussion with all of the doctor and department. And we launch the project and we invite the expert from Sutomo Hospital. However, the implementation is not easy. The
Yes, of
surgeon,
course.
the
Yeah.
surgeon were upset and complained to the director directly. General practitioner that help to fill out the form and consult to the team is stuck from the GP, from the surgeon and the team, and there were a conflict between the pharmacist and also the nurse.
Yeah.
So we respond it by make a lot of meeting again with, we ask the director of hospital leadership about the commitment again to the project, and we make collaboration between the nurse, GP, and pharmacy staff. One message that I always remember, we always remember as a team from the Drive AMS is start small and appreciate
Yes.
every progress.
Yeah. Of course.
So
Yes.
every conflict, every form, and
Yeah.
every meeting that we have to do, we try to make it as in positive way or the positive mindset as the it means that we moving forward.
Yeah.
Prof.
Yeah. I think
it's,
all of
it's
us
the message of
face
the
this
Drive AMS.
face
Okay.
this problem.
Yes.
Yeah.
I think it's
Okay.
it was I get the from the Drive AMS, and honestly the Drive AMS is one of the best or the best workshop that I've ever had.
Yeah.
Thank you very much.
Thank you. Thank you very much. So I hope we have Bu Ami now. Bu Ami, do you hear us?
Yeah, I can hear
Okay,
you clearly.
good. Yeah, so
Yes.
Bu Ami, so you are the only person from the Ministry of Health. So please tell us about the current key priorities to tackling AMR in Indonesia, and also the main opportunities and challenges in AMS implementation in Indonesia. Also, please tell us.
Okay, thank you, Prof. Anis. My apologies, I cannot be there in person because I have to attend a meeting, and I couldn't manage to be there in time, so I can only join online. So, regarding the key priorities for IMR containment in Indonesia, actually, in our national strategy for IMR containment for a human health sector, we already presenting the foundation and the pillars that we think that that is those are our priorities. We believe that strengthening the governance, increasing the awareness, and also providing the education is one of the priorities, and other priorities regarding the surveillance, regarding the other mechanism that support the IMR containment program. Also, the pillars about IPC implementation, about diagnosis, access to the health services, and the quality of medicine or quality of treatment. So all the priority are already all priorities are already within our national strategy. However, in short, for now, the Ministry of Health support the capacity of hospitals. So we started with we assess and we map the hospital because we want to ensure all hospitals are capable in diagnosis in diagnose the AMR bacteria through their own capacity in the term of their own laboratory, and they have microbiologists and they have the equipment, or they can access the diagnostic services from the public health laboratory. And second, we want to enforce and encourage the implementation of antimicrobial stewardships. In this year, we started from the Ministry of Health hospitals. We did the assessment to all Ministry of Health hospitals in their implementation of antimicrobial stewardships. And from that report or that assessment, we try to assist them in improving the implementation at their hospitals. And also we focus in strengthening the surveillance system in Indonesia. We collaborate with global PPS in IMU PPS. We also have a collaboration with Japan, the National NII, National Institute of Infectious Disease, for utilize the ASEARSnet for some hospitals. So it's just a pilot project, but we do many things in order to strengthening the surveillance IMR surveillance system in Indonesia. It is also applied to the IMC surveillance that is led by the DG of Pharmacy. And for the main opportunities we have in Indonesia in IMS implementation, firstly, we have a commitment of the government that we can see in the National Development Plan, that we have two indicators that actually very related to the IMS. The first one is about the percentage of government hospital or public hospital which comply to the with which the administer of systemic antibiotics, empirical systemic antibiotic, that is according to the guideline or to the antibiogram. And the second one is percentage of all hospital which are implementing the IMR program. So within our national development plan, two indicators actually very related to the IMS. This shown the commitment of the government. And also we have other policy that actually reinforce the implementation of IMS, such as accreditation, hospital accreditations. In the hospital accreditation standards, there are one element, or not one element, one standard 6.1 that specifically address the issue of IMS in the hospitals. And within the accreditation standard, hospital must fully comply all the element of the standards to get the accreditation certifications, or to pass the accreditation certifications. And also we have structure, responsible structure in the ministry, and we also have the committee as the platform for coordination and collaboration between stakeholders and between program and unit within within the Ministry of Health or outside the Ministry of Health. Also, we have a very close relationship and involvement from the experts and professional organization that help us in developing the regulation, the policy, and also implementing our program. Lastly, we also get many support from the development partner, such as WHO, Fleming Fund, and also from the other country in order to implement the IMR containment program. So challenges that we face regarding the IMR containment or IMS implementation is related to the characteristic of our country, the geographic characteristic, and also the size of the country. It's a very large country, so the implementation may vary between islands and also this distribution from uneven distribution of the microbiologists, of the equipment, of the capacity of the hospitals. And also the number of health facilities that quite large. We have more than 3,000 hospitals, more than 10,000 public health centers, more than 20,000, I believe, clinics and other health facilities. It makes the effort is quite uh, challenging and maybe also like resource consuming. So that is our challenges. And lastly, it's the awareness and literacy of the public regarding the IMR that we believe need to be improved. From the SKI national survey shown that 41% on average, 41% of the respondent actually they use antibiotics without any prescriptions. So that is more or less it, regarding the challenges that we face. Thank you. Back to Mr. Raj.
Thank you.
Yeah.
Thank you, Bu Ami. So many things have been done in Indonesia, and hopefully that it can scale up the implementation of antimicrobial stewardship nationwide. So, Dr. Licia, what are the practical and visible steps to implement AMS approach in a sustainable way in clinical or hospital setting? So from your experience in coordinating the Drive AMS here.
Yeah. Okay. Thank you, Prof. Anis. So yeah, I'm not clinician who work in hospital, so I think this is based on my observation of conducting studies and like assist hospital in Drive AMS program. So what I see is what is really needed in hospital is the first one is the awareness and commitment of the hospital leadership. I think this is crucial because even though like people from the ground, like maybe Dr. Dewi, Dr. Robert is excited and about the program, but if they are not supported by the hospital leadership, and so it's a bit difficult. So I think for sustainability, so it's not supposed to depend on the hospital leadership because sometimes what I see is this period the hospital director is, for example, Dr. A or Mr. A, and then the next period is the different person. So when the leadership change, um, often when the new director is not committed or not aware of this AMR problem, and then the program will going down. So, so I think to make it like a system in the hospital that this is a program that you cannot change. Whoever the leader, I think that's like that's one of many ways to ensure the sustainability. Yeah.
Thank you, Dr. Licia. So the last question for Peter. Yeah, so maybe later on also can be added by Caroline. So what could make Drive AMS a stronger model for international capacity building? And also, how do you see the Drive AMS can strengthening the collaboration between Indonesia and the Netherlands?
Thank you very much, Professor Anis and others. I was very happy to be invited for this panel because this project is so incredibly important because AMR is such a big possibility in Indonesia and in other countries as well, of course. I'm coming in from the perspective of education. I think my hope is that the lessons from the Drive AMS project can be mainstreamed in the Indonesian education system. But a few remarks on that is what I learned from being present in some of the trainings and talking to people like Licia is, and you hear it today as well, it needs a comprehensive approach. It needs to involve everyone, the whole team in the hospital, all layers. So that implies that the changes or adaptations in curricula, for example, will also have to be done comprehensively. It's not enough to just train doctors differently or nurses. Also, the managers of hospitals need to know, etc. So that I think is a challenge because the responsibility for curricula in Indonesia tends to be a bit fragmented over different ministries and so on. So I think that's something that would require some further work. And then, of course, to align it with what needs to be standard operating procedures in hospitals. And that needs to be consistent. What young people will learn if they're being trained for a future job. And then when they move into the hospital, that they can implement that. So there is definitely still more work to be done there. I think this offers ample opportunities for continued collaboration with the Netherlands. And let me bring in one element that was not yet mentioned here. AMR is incredibly important for people. It is incredibly important for animals as well. And that's where, the Dutch agribusiness is very much present in Indonesia. In chicken and so on. And there is a relationship in the issue. And that is part of the Dutch-Indonesian connection and also the trade relationship. So I think there will be ample room for further work together with the Radboud University, also with other universities in the Netherlands that are working on this issue. So I do hope that in the years to come, this can become a stronger part of the bilateral collaboration. Thank you very much.
Thank you, Pak Peter. So, Caroline, do you want to add something for this?
Maybe very briefly.
Yes, please.
So I agree with everything that has already been said, and I think, since AMR is a problem that can only be addressed together internationally with international collaboration. So I think Drive AMS is an excellent example of how best practices and experiences from one country can be sort of translated to in close collaboration can be translated to a different context, and and this can then also be the lessons learned can then again be implemented in different settings. So I think it is a really nice example of good international collaboration, and I think that is the only way to go if we want to curb the AMR problem worldwide. Thanks.
Yeah. Thank you. So maybe the last statement from me. So please give me 1 minute, Jeroen. So
Sure.
I think due to the great disparity in terms of capacity among hospitals in Indonesia, we hope that the Drive AMS can be the answer. I mean, it can give us the innovation how to implement the AMS based on the capacity of the hospital. So from maybe in the center like Jakarta and also in Papua, which is very far, the remote area. So I hope that using Drive AMS, we can, we can adapt in a different way. Yeah. So this is the hope, Pak Peter, also that we do this, the Drive AMS, not only in the big city, but also in the remote area. Thank you. So I give back to you, Jeroen.
Thank you so much, Professor Anis. And I would like indeed to say a couple of words about that. I think what was very interesting is that that it was said earlier, also now here in this meeting, Robert mentioned that there's a lot of difference between some hospitals are actually quite well equipped. They already have equipment available. The diagnostics are running. There's a team, etc. So the prerequisites are already there to really start thinking about a program like Drive AMS. But because remember, Drive AMS is a program that helps really the changing of the prescribing habits. And I think it's very important, but it's also you can only start with that when there's a team. And I think there's a team, there's materials there, there's guidelines. I think nationally spoken, I mean, guidelines are there, but the presence of relevant sort of prerequisites before you can get started, it's really important that they're there in those hospitals. So I think what we're doing now, and that's really interesting to see, I think Licia could talk another hour about this. We don't have the time, unfortunately, but that different hospitals take different decisions, and they take different aspects of care. Some will focus on perioperative prophylaxis. Others will actually focus on, for example, what Bu Amy mentioned, the appropriate prescription according to the guideline, the empirical prescription, and they will form a project around that. What we hope to achieve, and that's where the challenge is that people learn how to set into motion a change management. And I think that's what people would need to learn, and they need measurement for that. So I'm also very happy, and it hasn't been mentioned broadly, that the vast experience that Indonesia has with different methods to measure also the quality of antibiotic use. So not only the resistance, but also measuring the quality of use for using the Geiser's method, but now also using the GPPS method or the PPS method, which has been very welcoming, I think, during the course and also during the projects that Licia is managing. I think what we see is that people need to learn a sort of a consequence or stepwise procedure to do things. My biggest challenge, or our biggest challenge altogether, is obviously how do you scale that in a country where, as Bu Amy mentioned, we have like 1,300 hospitals and so many. We haven't even talked about Puskesmas. So that's a challenge, and I think that's where we need to work together to see when we can also find innovative solutions to make that more rapid. And I do hope. And this is maybe some final words, but I do hope that we will keep this collaboration between an educational partner, which is NAFIC, a government partner, very importantly, Kemenkes, but also academic partners like you, Prof. Anis, but also like Robert and partners from the field, like Budewi. We all keep on working all together to find those solutions to make it scalable, because the challenges indeed are enormous. They're very different from the Netherlands. But I do think that the collaboration has been such that we can move to a second step, if you want. So I hope that Drive AMS 2.0 is going to happen. We are going to organize the next course in the start of the next year. But I hope it's not going to be the end of the relationship. It's going to be something that we will follow up over the next couple of years. So I'll leave the last word for you, Prof. Anis, to close the meeting.
Yeah. So thank you very much for all the panelists. I think we don't have time for question, right? Jeroen, or is there? Okay. So there is one question.
Go ahead. Yes, please do. Yeah.
Thank you. Nice discussions. Natalie Winkles-Melchers from the Wageningen University. We also actually, in our project here in Indonesia, we also have a small section on AMR. But I was happy that you brought up the animal health here. I do think that I haven't heard the Indonesian counterparts talking about animal health at all. I know IPB is having a animal department where they actually test samples. So my question to you is, how are you going to connect the animal health as well, because a lot of what happens in humans is arising from what happens in animals. And my second point is that I was wondering, I think this problem you can only entangle if you also look at over-the-counter medicine, because that's another very big problem. Thanks for that.
Please.
Good evening to all speakers and panelists and all the participants. My name is Teguh Reza Firasi. I'm a veterinarian from Dean of the Faculty of Veterinary Medicine in Universitas Syah Kuala, Banda Aceh, Indonesia. I just want to share a little bit the result of our small study we did in Aceh. We did a research collecting sample from the traditional market in several traditional market in Aceh, in Banda Aceh, and the surrounding district there. It is interesting based on One Health approach. We look on the possible transmission from poultry sale in the market, and then to the poultry sellers or traders in the market, and also from the facilities they use. It is interesting to, from our study we found, there is the high resistance from the poultry product, and also half from the sellers and the facilities. But when we compare between different markets, they are different prevalent as well. This is interesting if you look on the hygiene, sanitation, and everything. I think will be another avenue to study in the future from our, if we can do a collaboration. Thank you so much.
So thank you for the sharing. So I want to answer you. So we have the National Action Plan, and it is made with the One Health approach. We try to discuss together and make the same target to decrease the ESBL producing E. coli. So maybe you can see our National Action Plan and the website, and there are some program that actually it is not really One Health. We make all the plan together, but then implement in each ministry. This is the first thing, yeah. And then the second one, so I have a research collaboration with Professor Jaap Wagenaar from Utrecht University. It's about the colistin use both in animal and in the broiler, what do you call the chicken? Yeah, and also in human. Yeah, but it's still on progress. Yeah, but I think we need more and more study, or also anything collaborative program in both sector. Thank you. Yeah, it's time to close the session. So again, thank you very much for the discussion and also the presentation. So Teske here. Yeah, so thank you, and we hope that we can have proceed with the future collaboration. So bye,
Thank you
Heroin.
very much. Thank you very much.
Thank you. Bye-bye.
Thank you. Bye-bye.
Yeah, so thank you.